Here's another example of focal asymmetry on a mammogram, which corresponds to a region of normal breast tissue on ultrasound. In this case, we said, okay, we're not so upset about this area anymore. We don't think it needs biopsy. This woman tells us that she's had previous outside mammograms at an outside institution. We're going to give it a few weeks, try to get those films. Sure enough, we did, and we could see that this area was perfectly stable for years and years. So it was the ultrasound that helped us kind of not be so suspicious of this region and led us away from biopsy, so that ultrasound can lead you towards appropriate biopsy and lead you away from unnecessary biopsies. Here's a man, and this is both breasts, cranial caudal view. On this breast, you see kind of the classic mammographic findings of gynecomastia. On this breast, it looks more mass-like and doesn't look classic at all. So for this breast, we would actually do an ultrasound. And indeed, we did find a suspicious mass right behind his nipple, which he could feel, which did turn out to be a breast cancer. This is another retroareolar mass in a woman with a painful, red, tender breast. And in this case, here's the thickened skin, and this was an abscess. It looks very much like the breast cancer, the male breast cancer. But again, you have to put everything together with the clinical picture and come to your diagnosis. But ultrasound can be very, very helpful. Ultrasound helps us with implants, as I said a little while ago, not so much anymore with telling whether or not an implant is ruptured, although we do have ultrasound criteria for that. We usually defer to MRI for implant rupture. But we have criteria, if MRI is not available to you, to be able to tell whether or not implants are ruptured. We like to use ultrasound for implants more so to look at the breast tissue that surrounds the implants, because sometimes that can be difficult mammographically. And here we see a mass overlying a breast implant. Here we see signs of intracapsular implant rupture. Here's the implant surface. Here's the breast tissue and the skin. And all of this, these hypoechoic regions underneath the surface of the implant, are all signs that the implant has ruptured, but that the rupture has not extruded into the region of the breast tissue. Here's another sign, and it's correlate on MRI with the Linguini sign, it's called, of intracapsular implant rupture. And here's a person who felt a mass at the 2 o'clock position of the right breast, and when we did the ultrasound, we could see this classic sign of implant rupture. Here's the implant surface, and here's the break in the implant surface with this region of silicone, which is extruded into the surrounding breast tissue. So ultrasound can see intra and extracapsular implant rupture, but now we use MRI to be more specific for the diagnosis, and we use ultrasound more to look for masses in the breast tissue overlying the implants. Here's a galactogram or a ductogram, which shows a filling defect in the duct. Ultrasound was helpful here because it actually showed the mass which corresponded to that filling defect, which we then did an ultrasound-guided biopsy of and proved that it was a papilloma. Here's another example of a palpable mass on a mammogram where there are extensive calcifications, which when they look like this, there's a good chance you are going to see them on ultrasound and that you can use ultrasound as a guide for biopsy, and here are those calcifications on the ultrasound. Now, most importantly and most interestingly, we use ultrasound to help us tell whether a solid mass is benign or malignant based on certain criteria which have been well established. I am not going to go into a lot of detail with this now, but there are categories, and I'll refer you to the BI-RADS ultrasound characteristics to differentiate benign from malignant. We'll go through them generally. Benign masses tend to be ovoid in shape, parallel to the skin surface, have smooth margins, gentle lobulation, are homogeneous, and are isoechoic or hypoechoic to the surrounding fatty tissue. Malignant masses tend to be non-parallel. Their margins tend to be spiculated, angulated, indistinct, heterogeneous, hypoechoic to fat, and have not an abrupt interface with the surrounding tissue, but rather are surrounded by an echogenic rim. Here's an example of a simple cyst When you see the 3 classic signs of a simple cyst, you can diagnose a cyst with about 100% certainty, and they are that you have a nice circumscribed margin, the mass is completely anechoic, and there's a nice band of enhanced through transmission behind it, diagnosing a cyst with almost 100% certainty. This is a parallel mass which has smooth margins, circumscribed margins. In order to call a mass circumscribed, the margins have to be circumscribed over approximately 75% of its borders. Ovoid, circumscribed, it has a nice chunky calcification. It has nice sonographic characteristics of a fibroadenoma, which is what this is. Now here's another parallel mass, but this isn't what you would call nice and sharply circumscribed. As a matter of fact, these borders are not smooth. They're microlobulated. Microlobulated meaning more than 2 or 3 gentle lobulations. There are more than 2 or 3 lobulations here. So this part of the mass would fall nicely into the characteristic of a benign mass based on its margins and shape. But when you get to this part of it, it does not. So this is a mass which we would recommend a biopsy for. It did prove to be a fibroadenoma, particularly proliferative cellular type, but we would not let this go without biopsying it because of this part of the margin. And then this is just more of that. This falls clearly without the characteristics of parallel. This is actually a mass that is slightly taller than it is wide, or non-parallel, or vertically oriented rather than horizontally oriented. It's very microlobulated, much more than 2 or 3 lobules. Part of the margins are indistinct. You can even see some mild spiculation along part of its margins. So this is a suspicious mass, very typical in appearance for what a breast cancer looks like, and very easy to do an ultrasound-guided biopsy. This is also an example of the echogenic halo that can surround some of these masses, which indicates that there, as this mass has grown, it has set up kind of an inflammatory fibrous reaction around it, which has created this, this interface. And then this is an example of a mass that's very poorly kind of seen. It's not sharp, it's not circumscribed, it's kind of fuzzy and hazy. It has indistinct margins and classic signs for malignancy. Here's another classic malignancy, taller than wide, ductal extension, microlobulation, angulated margins, not sharply circumscribed. This would be BI-RADS category 5, definitely ultrasound biopsy. Another example showing a little bit more of the characteristics of ductal extension. This is a mass that I like to show you because it brings the point about the internal echotexture. When we talk about masses being hypoechoic or hyperechoic, we're talking about them being hypoechoic or hyperechoic relative to the surrounding fatty tissue. This is the surrounding fatty tissue. This is the mass. This is profoundly hypoechoic relative to the fatty tissue, but it's not a cyst. Actually, there are some internal echoes. It doesn't meet the marginal characteristics of a cyst. It's not sharply circumscribed. It's lobulated. It's indistinct. This is a mass that's almost as anechoic as a cyst, but does not have enhanced through transmission, and actually is what many cancers will look like. Very hypoechoic in comparison with the surrounding fatty tissue.